Dr. Geyer, thank you so much for coming on the show. I really appreciate it.
Erin, what a pleasure to be here today.
Yeah, well, and I really appreciate it as well. You giving me the opportunity to read and review your book. I know we'll be talking about it a lot today, Ending the Crisis, which you published in conjunction with Mayo Clinic, where you are employed and where you work in Arizona. And I wanted to start actually just by talking a little bit about your book and asking you where the motivation to write the book came from. Having read it, it is so incredibly deep. I remember I was going through this book and reading chapter after chapter and being like, wow, I could not imagine both a more thorough but accessible overview of this material for anyone who has opioids in their life, or if their loved one has opioids somewhere in their life. So can you tell us a little bit about where that inspiration came from and the process of writing the book?
Yeah, thank you, Erin. Everyone's got a motivation behind something that we see materialize in this life. And mine is probably a compilation of a lot of things, but I grew up in the addiction treatment industry. My parents had started a drug treatment program, and it was essentially from scratch. As a little kid, I saw this get built up to what's now more than 1,000 inpatient beds. And having lived in that world and seeing what works, what doesn't work for clients, I then exited and entered the field of medicine, where really the addiction treatment field couldn't be further away from our mind, right? That in our perspective from the medical world for so long was a mental health problem, or it's a societal problem, or a criminal problem, or something that it doesn't really fall into our realm. But the more I understood from an opioid perspective, the tremendous role the medical community played in driving the opioid crisis, the light bulb started to go on. Where did we start to go wrong? What role do the medical practitioners of our day play in getting us out of it? And the more I studied, the more I realized everything. That this is absolutely a huge part of our industry, something we need to take ownership of, and ultimately something we need to be a tremendous part of in managing. As I surveyed the literature out there, I came to the appalling understanding that, oh my goodness, we may have this knowledge as practitioners and providers on how to use opioids safely, and how to store them, how to ensure that people are the right individuals to receive them. But are we passing that on to our patients? And there was no reference or handbook out there for them. Hence, Ending the Crisis, Mayo Clinic's Guide to Opioid Addiction and Safe Opioid Use. That book really represents a compilation of some of the best minds in our industry, all coming together to tell patients how to use opioids safely, when they're appropriate, when they're not, what drives pain, what makes it better, what makes it worse, and really how to navigate opioid-related complications, addiction, overdoses, and then the tremendous role friends and family play in helping someone who's struggling with those problems as well.
Oh, well, and everyone's got a part to play. And you make that point numerous times in the book, that it's something both in terms of a societal level as well as an individual level. There's so many touch points and areas in which there can be improvements made. And I think your point also about how knowledge and information is everything is so astute. I remember this probably was, maybe about like 9 or 10 years ago now, when I first, prior to my role now, I was working as an administrator in a hospital. And at the time, literally the second day I got there, I got pulled out of my orientation to go to a system-wide meeting on the opioid epidemic, where the chief medical officers and heads of different divisions, they were all there to talk about what do we want to do in terms of the opioid epidemic. And I feeling a little bit bold, and also because they looked at me and were like, well, what do you think? You're the new director of addiction services. I just talked about ideas that I had read, because I was very much up on best practices in terms of how, what conversations should we be having with patients? What would best practices be? And it was shocking to me, because we, as this being our world, are so immersed in it, how other folks just, they weren't at the time, but they were so hungry for that knowledge and ready to use it. And you put that in the hands of someone who needs it, and really good things can happen.
It's so true. I had someone make the reference to my book as a bumper sticker on the back of a school bus. I said, "Sir, explain yourself." What do you mean? And he said, what do you see on every school bus in America? It says, "This school bus stops at all railroad crossings." And they said, if you look at what's happened with the opioid epidemic, there are so many systems issues that could have prevented what happened from happening, but they were all outside or external to the patient. And I think that's a misunderstanding amongst patients that there's going to be, no chance that they're going to experience complications personally or have long-term problems because the FDA is overseeing the process and make sure that the drugs are safe, that the medical prescriber is well educated on when drugs are appropriate or not appropriate for this certain situation, that the pharmaceutical industry has the patient's best interest in mind through this whole process, that the nursing protocols will keep them safe to catch any issues if they're coming up. And all of these, really, the railroad tracks, the train itself, the train station, the cargo is enough to keep us safe. But the reality is it's not. We've proven that. Mm-hmm. And that school bus that pulls up to that bus stop or to that train station, I should say, or train tracks and stops and says, you know what, I'm going to wait. I'm going to look both ways. I'm going to think about this twice before I go across that is the last line of defense. That's what we want to empower our patients with. The knowledge that we as providers are, truly privileged to have in their own hands, in their own time. And this book was really a compendium guide to help them do that.
Absolutely. And I think you've definitely accomplished that goal. It's amazing how much of a difference, even just having the conversation or even just like a modicum of knowledge can do. I forget, I don't want to ever say stats that I don't know are true, but I remember reading an article at one point talking about how the percentage of patients who had a conversation with the provider when opioids were being prescribed to them about risks and benefits or about chemical dependency and about how if you experience some of these chemical dependency symptoms that it's okay to talk about it. In fact, you probably really should. And there's this assumption that, oh, my physician's prescribing this for me, it must be okay. Or even the best way to manage pain, or if a patient's having a problem, they'll tell me, and those aren't necessarily safe assumptions.
Not at all. Our organization had done a large national survey across the United States of just general people getting a perspective on the opioid epidemic in 2018. And we found some appalling misunderstandings amongst the public that clearly reflected us not doing what was in their best interest, and that's educating. More than 50% of the general public thought fentanyl was not an opioid. Less than 30% of the general public said that their doctors had even sat down and talked to them about the risks and the benefits of opioids or had open conversations about when they should be de-escalated. These are things that are on us as providers to really relay to patients. But if it's not happening, they need to be prepared with the information themselves from another source.
Yeah. My mind goes towards actually one of the most proactive physicians I worked with as we were modifying our procedures in that health system was an orthopedic surgeon who, when we had the first meeting with orthopedic surgery, he actually was very brave and came out and said, I am one of the people who was part of the problem. Every patient, every procedure, I would give them 80 hydrocodone, 80 Norco, with one refill post-dated by a week. So basically every patient got 160 pills regardless. And now certainly opioids are very indicated after certain orthopedic and spinal surgical procedures so that you can go through the proper PT and OT, very important for regaining function. But that should still be tailored to the individual and to the procedure. And that's the sort of thing that happened in the past with the idea that it was compassion, right? They're not going to run out. They're not going to be stuck in pain. But as a result, then people sometimes would over-medicate themselves or have it sitting around for kids to get at. There was just this assumption that everything would be okay when actually not so much.
We had a rather damning study that was done internally for our organization that's since been replicated by many other organizations, looking at prescribing habits and what was done with pills that we were giving to patients for surgical procedures. We found overwhelmingly back in 2017, more than half of all of the prescriptions that we were writing for patients were actually being used. I should say less than half were actually being used by the patient. The rest are sitting in medicine cabinets or free access. And of those that are left over, patients oftentimes were not destroying them. They were keeping them for prolonged periods for, the next do-it-yourself home project. So there's great opportunity there to really educate the public. If you're done with your pills, if you don't need them, don't keep them around, destroy them immediately, because when they're used for other indications, they can cause more harm than good.
Mm-hmm. Yeah, well, and I think I know as we go along today, we'll talk a little bit more about the waves of the epidemic. I feel like there have also been waves of education where it's like I feel like a lot of the public now does know about fentanyl. I feel like there was a big wave a few years back about like the different brands. You mentioned Deterra in your book. That's one brand as well that I've come across a lot and have used a lot, and which is a medication disposal pouch where you can safely dispose of opioids at home. But I feel like there have been these waves of like, hey, like the public needs to be informed about this, or healthcare needs to be informed about this. And sorry, go ahead.
You're absolutely right. What we've recognized is that when we partner with patients, it becomes this synergistic approach to ensuring that everybody stays safe, right? The patients and their loved ones and our communities are all working together to solve the crisis. And education is going to be key to that on what to do with those drugs. I think one of the first things patients need to understand is their indication. And I think one of the greatest misunderstandings out there is that opioids are the go-to medicine for solving life's problems, when in reality, they should oftentimes be, with the exception in moderate to severe pain, our last resort, right? So using them adjunctively with other medicines like scheduled Tylenol or scheduled ibuprofen is a great way to minimize use of opioids, if an opioid is even given or indicated for the condition. And if it is, making sure that you know how to store it safely. The moment it gets home, it gets locked up. And I can understand as a patient how you'd want to keep it handy or keep it in the pocket. I'll tell you what, kids know that, and studies show it. Kids know how to rummage through our medicine cabinets, our kitchen cabinets, and our old laundry that we've thrown in the hamper. Get rid of the drugs when you're done with them, too. You do not need to finish the bottle. If your pain is well controlled near the end of whatever your course of illness is, just destroy it. And like you mentioned, taking it to a pharmacy for them to destroy is often a great option. You can look up the DEA website, and there's take-back locations across the country that you just enter by zip code on the website. You can search that way. Mix it with unpalatable substances. My husband said my cooking's a great option. So find a way to destroy it and get it out of the house.
Yeah, well, and you know, this reminds me of I was having a conversation with a psychiatrist from Brown Children's Hospital who works on problematic interactive media, so gaming and tech, and he was talking about social media being like a chainsaw, where it's a tool and it's got a purpose and it can do something very useful. But if a kid just has this in their hands and they're just using it, then they can cause a lot of damage. You can't just give a kid a chainsaw. And I feel like opioids are the same sort of situation, where they are a tool for a purpose, and they have a purpose, and they can be extraordinarily useful. But if you just put them out into the wild, into everybody's hands, like, full disclosure, I have never used a chainsaw. I would be very cautious, but there's some intuitive amount of like, those are sharp teeth. I've seen movies of lumberjacks and things, I'll be very careful, but it seems like we've just been a little slower on the uptake with opioids, but it's so important that we see them that way.
You're absolutely right. What we talk about frequently in the book is that opioids serve a purpose, and vilifying the drug class is actually part of the epidemic. Because what it does is take the other half of the American population that misunderstands their risks, over amplifies them, especially from a media perspective, and said, you end up with a person that's scared to death in legitimate circumstances to be using them because of the risk of addiction. I've had, little old ladies riddled with cancer that refuse to touch an opioid even near end of life because they don't want to end their life addicted. That's not how these drugs work. And so making sure that we understand how opioids are used safely in the right person, for the right indication, at the right dose, with the right drug, through the right route is key. And partnership with your provider, asking those questions, am I the right candidate, is the first way to start that.
Yeah. Well, and I think that's a good bridge to my next question, which has to do with the partnership between patients and their providers. And you emphasize this in one part of the book, that it's so important to have a healthy partnership. And that's been one of the themes that I've seen in folks who I've worked with who have had opioid problems, either they're working with me because they've just, something's happened with their provider and they've been sent to me, as an addiction specialist. But there's a lot of times when I'm talking to somebody and they've said, whether or not it's alcohol or opioids or otherwise, that they're feeling very reticent to tell their provider. They feel like they're going to be judged. They feel like it's going to be this really negative experience. I know for opioids in particular, there's this fear like I'm going to be punished or cut off and be put into withdrawal and those sorts of things. I think, and I promise I'm coming to my question, I think the other layer on this that I know I've run into in a different area as well is about trust in the healthcare system in general right now. I feel like there's been a big knock to that over the past 3 years, where when we look at the data, there's more and more of the general population that looks at healthcare institutions, whether or not it's hospitals, individual physicians, or even the CDC, where people look at us in healthcare with a lot more skepticism than they did before. So my questions to you are, for those in the audience who are on the patient side, what would be your thoughts to them in terms of perhaps how to approach their care teams and how to work through any misgivings or hesitance they might have? And then on the other side as well, for those of us in healthcare, what can we do to engender that healthy partnership that you talk about in your book?
Oh, Erin, I'll tell you that the first thing I would say to our audience is, I don't blame you for a healthy skepticism. What we saw up until about 2016 was that physicians were largely overprescribing, not monitoring their patients while on opioids, overprescribing, not using them for the right indications, and really creating a crisis on behalf of our nation in conjunction with so many other elements. In 2016, we saw those CDC guidelines on the use of opioids for management of chronic pain come out. And once we read those, the light bulb went on for really the whole field of medicine to say, we need to be much more comprehensive in the way that we're managing these drugs. We're creating problems. And what we saw, though, was really the pendulum swing to the opposite side. Patients that were now very much dependent on the drugs, and dependent, by the way, not in addiction state, just using them chronically, physiologically dependent on them, and very likely to go through tremendous withdrawals if taken away. Those groups of people now found their providers completely unwilling to offer opioids to them, cutting them off cold turkey, saying, this is not an industry I'm going to get into anymore. I'm causing problems. Those people, according to the data, oftentimes found the source to treat their pain, to treat their ongoing dependency with illicit sources of drugs, and the overdose epidemic spiked tremendously. So, the pendulum from one side, we're not watching you closely enough, to the other side, we're not managing the complications we help cause, is more than enough for the average patient to say, what are you doing to me when I come to you for my pain? I don't blame them. I think the most important thing patients need to understand is that we've learned so much more. And I think humility is the first way for us in our industry to approach the topic and to say, listen, we're going to do this together. We know these drugs, somewhere between 3 to 19% of patients are going to cause problems. And if you're one of them, it is not me versus you. It is us versus the problem. And we're going to manage it collectively. Be open about what you're experiencing. Tell me your symptoms. If you're getting a bit of a buzz, or if you feel like you're using your drugs for indications other than prescribed, don't be afraid to talk to me. Let's sit down and let's navigate this together, because we have treatments and we have options for you. We're starting those conversations, Erin, and we're going to get there. But I feel for our patients. It's been a roller coaster ride.
Yeah. Well, and so I think that approach of humility is one. When I think of the best doctors, that's what comes to mind in terms of those, or those at the very least who are not judging of any health condition, addiction or otherwise, where this is a problem. Let's work on it. Let's fix it. Let's be a team together. I think for some patients, there's this added layer of, if the doc themselves is the one who, say, prescribed the medication. I've seen this sometimes with benzodiazepines as well, like your Ativans or your Xanax, your Klonopins, where they kind of feel almost accusational about it, or that there might be some sort of punitive approach. And even heard some stories of some cases where people have had very bad experiences talking to their care team about it, What would you say, if we're sticking on the patient side here for a second, if you feel like you're having a tough time with your physician, or you did disclose something and felt like it didn't go very well, or now you're kind of in like a rapid taper and having a very bumpy ride out of where you got to, what would you recommend that someone does to try to make sure that they don't end up going to the street where they run into something worse like fentanyl or xylazine or what have you?
Erin, your question is exactly why we wrote this book, because patients deserve to know what we know. And I'll tell you, if they can familiarize themselves with the content on when, how, and why we use opioids, that's a great starting place to have these conversations on an educated basis. Not every provider knows how to have these conversations well. And I can tell you, providers have been burned. Providers come to this whole conversation oftentimes with the perspective of, I don't really understand addiction well. It's really a mental health industry problem. And my patients aren't listening to me when I say they need to cut down, or they're fighting with me, or they're calling my office at all hours of the night, or they're leaving angry voicemails, and I just can't deal with this problem. And here's another patient on my list I'm going to see today who's coming in with chronic pain syndrome, who's going to ask me for more opioids. And we're done with this. I'm going to cut it off. I'm going to tell them what the rules are. And if they're not going to adhere, they can go somewhere else. I see this a lot, Erin. And then we see the other side of the coins where the patients have felt that they are dealing with true, maybe complications or just chronic pain syndromes from opioids. Or it's the reason they use opioids, and they know that their doctors are going to be hostile, that they're going to put up roadblocks, that they're going to make this harder. And if the patient can just advocate more for themselves or demand their point more. And as you see, that the conversations are going to dissolve when we start it with those perspectives. I heard it best from someone who has these conversations in and out, one of my good colleagues, who said when he meets with a patient for the first time who's on opioids and very much feels the need to meet them, that conversation isn't about opioids. It's about that person. They want to know about their life. They want to know about the things that drive that person and gives them quality of life. They want to know a bit about the pain background and what are things that may be inhibited in that person's life because of opioids. What are things that are augmented? Learn about that person and then use that as an opportunity to explore what that person wants out of the relationship with the physician and the relationship with the drugs. The point of taking any drug is to improve or enhance life, to have the benefits outweigh the risks. And I will say, oftentimes with opioids, you can achieve that balance. Sometimes you can't. Start off with openness and understanding and a willingness to talk. Yeah.
Well, the communication and conversation is so essential. And as we've said multiple times, I think this will be a through line for the day, that information is essential. One of the chapters I really appreciated in the book was the one where you really dive into all of the different, both pharmaceutical and interventional options for pain control. And I know that just for me, not being a pain specialist and also not being a physician, I'm a psychologist. When I started wading into this world of opioid policy and prescribing guidelines and all of that, I was blown away at the number of different techniques there were for pain management out there that I feel like the public doesn't generally know. Even those who are struggling with chronic pain, if they haven't, say, been to a pain medicine specialist and talked about these options, they may not be aware. And so a question I have for you in terms of your motivations for writing the chapter, as well as your experiences in practice, is your impression that a lot of folks struggling with pain aren't aware of the different options that are available, or are there particular gaps in certain places? What have you noticed?
You're absolutely right. We wrote chapters on pain and pain management because there's a very big misunderstanding in the public that there are different kinds of pain. And because of that, there are different treatments for those different kinds of pain. In our survey, we identified that almost half of Americans thought one of the greatest indications for opioids was management of chronic pain. And we couldn't have gotten that message more wrong in America. We know that acute pain that's related to an injury or damage to the nervous system, serves a purpose. Pain prevents us from overusing a limb, prevents us from redamaging. Acute pain is there to allow us to heal, and we need to respect that. And so oftentimes going after a masking approach, which is honestly all opioids offer us, they don't treat anything, they mask. Going after an opioid can actually impair healing in many circumstances when someone's experienced an acute injury. So that's why we want to try other targeted relief efforts, right? Using some degree of pain control with other medications and then adding on opioids as needed for breakthrough pain in the setting of acute pain. As pain transforms over time from acute to chronic, typically after 90 days in some populations, that's when we start looking at alternative mechanisms to really start getting a better control on pain. Interventional procedures, topical agents, long-acting medications that work on the brain and other parts of the nervous system that stop those triggering cycles that really seem to drive that pain cascade that may no longer have anything to do with the original source of injury are key. What we do know about opioids and chronic pain is that in more times than not, according to the literature, they cause more problems than benefits. Those opioids bind to receptors in the brain and start stimulating brain pathways that make you very dependent on use of opioids to be in a state of relief. And oftentimes they actually drive pain as opposed to improving them. The natural history of opioids is to require higher and higher doses over time to experience even less and less degrees of effective pain relief until you're in a state of high levels of dependency and experiencing all the side effects, all the consequences, and almost none of the benefits. How is that helping a patient? Education on that part of it is key. And I think we're getting to a point in society where we're talking about this more, but not enough.
Yeah. Well, as well as, and this was a point that you made very, very assertively in the book, and that I very much bought into back when I started wading into this world, was that pain management is not the same thing as pain elimination. That it's about restoration of function, about reduction in pain and pain tolerability. But if your goal is to just numb out, that isn't necessarily the best for healing, and there's potential very negative side effects to trying to totally mask or totally eliminate that pain.
It's a big mindset change that we need to make in this country, including with providers. You know, historically, our goal has been elimination of pain. And I could go into great detail on how the development of the opioid crisis set that standard. But what we've recognized is that functionality should be the goal, not elimination of pain. Are you able to do activities of daily living? Can you walk your dog? Can you hug your kids? Can you take them to the park? You know, those basic things that give us quality of life and help life move on is what we want to go after. Elimination of pain, if it's achieved, wonderful, but it's not what we're really going after at the heart of pain management.
Yeah. Yeah, for sure. Well, so in the essence of time, I know I've only got you for a little bit. I want to make sure we talk a bit about the opioid epidemic and the overdose epidemic specifically, and some of your insights about that. We were chatting before the show about some very recent news about how naloxone was just approved for over-the-counter OTC sale. That here we're recording here at the end of March. And I found that I even had a misunderstanding about the full implications here of, say, the differences between a standing order, which we've had, where you could say get naloxone from a pharmacy even without a prescription, versus what OTC would functionally mean. So for our listeners who don't necessarily know of those nuances or haven't heard the news, could you walk us through what's just happened and what that means in terms of naloxone availability?
Yeah. So what happened yesterday means that those people that have needed it the most now have much greater access to it. Historically, one of the only ways you could access naloxone was behind the pharmacy doors. And so if you wanted the drug, you would have to approach a pharmacist. And the good news is in almost all 50 states, there's a standing order prescription system such that you don't need a prescription from your physician in order to request that drug from the pharmacist. The pharmacist could then offer it to you essentially through your insurance company. What happened yesterday was to bring it from that side of the counter to the other side of the counter and make it much more widely available. Grocery stores, gas stations, vending machines, just about anywhere that you can buy Tylenol or ibuprofen, you're now going to be able to buy Narcan. Now, we don't know some of the other nuances associated with this. What will the costs be? I've heard numbers somewhere between $50 to $150 for the over-the-counter version. Right now, through a prescription, it's somewhere $25 to $30 for the average person. Will that be inhibitory? Maybe. And then, of course, there's the ongoing stigma. If someone still has to bring it up to a cash register attendant, is there going to be barriers there as well? You got to wonder. But it's one step closer to improving access.
Definitely. I mean, it's so available. And just thinking as well, like if I know in so many grocery stores, or even just like thinking about like a Target, there are self-checkout lines where you could just, pick it up and take it out that way, and then not have to worry about like, am I going to get an eye from the pharmacist when I ask for it, or an eye from the cashier even? But even if you do, right, if it's something that's necessary, it's there for you. And that's a huge, huge change from the way things used to be.
Oh,
Sure.
there's tremendous stigma on this there, and it doesn't end. I've been the personal recipient of it. A few years ago, I was at a park, a very affluent park, mind you, where every kid is well dressed and nice parents in a working class neighborhood. And I heard screams from behind a building. I ran over there with my 3-year-old in tow, only to find probably a 10 to 12-year-old lying on the floor. He was blue, and there's a bunch of teenage friends around him screaming for help. I'm standing there unprepared, Erin, and EMS arrived literally within minutes, fortunately had naloxone, and the kid was revived. It was another laced drug, I would imagine. Probably thought he was using cannabis or something else that, like many of the drugs out there, are tainted with some of the synthetics. But on that drive home, I stopped by a pharmacy, and I sat in the line for 20 minutes with a screaming 3-year-old in the backseat, and I picked up that drug. I'm going to keep it with me at all times, because who knows where this event's going to recur. But of course, like any good patient, I tried to tell my provider about it, and I put it on my medication regimen. And as we're going over our medications, that provider got to the drug naloxone sitting on my medication list and said, Dr. Geyer, I see naloxone here. Is there something you want to tell me about? Should we talk today? And I was happy to talk. But we feel that, we feel the pressure of why would someone carry naloxone? And I want to get over that hurdle of society. The reality is those at highest risk absolutely should have this drug. That's people that use high daily morphine or high daily opioid requirements, individuals with a personal history of overdose, or those that struggle with addiction, people with baseline heart or lung conditions, kidney or liver conditions that use opioids, and any other circumstances that a provider brings up. Keep that drug with you. Make sure loved ones are educated on how to use it, because the odds of you as the patient using it are probably pretty low if you're experiencing an overdose. And then make sure that you get a refill if it is used, because that's a high risk for a relapse in the future.
Oh, definitely. And I just also want to put a plug for carrying it around for any number of reasons. You never know if you're going to run into somebody, and they're so small. It's not that difficult at all if you're carrying a briefcase, or depending on the size of your purse, maybe that's a little more difficult. But it's not that big. It's very easy to carry around. I know that for me as well, it's helpful sometimes if I run into someone who could really use to have it with them. I could just give them the dose that I'm carrying and then go get another one. And that's something that I've done for a long time as well. Even before it was, there was a standing order, or now that it's over the counter. I just want to put a plug here also for county and city health departments, which almost always have supplies of naloxone, of Narcan. That's the nasal application version on hand, and they'll just give them away for free. You can get them from them the vast majority of the time free of charge, because that's what the health department is there for. So I don't know if you have any reflections on that as well, Holly, but just always having it with you never hurts. It doesn't hurt.
If we feel comfortable carrying around ibuprofen and Tylenol, I think we're going to get there as a society with something like naloxone. And the benefits are, if it's delivered to a person who's down, who is not experiencing an overdose, no harm done. The side effect profile is virtually minimal. If it's going to work, it's going to work. If it's not going to work, then really nothing else happens, and you should still be calling 911. But that's another key point I would make. Every overdose is a medical emergency. Call 911 at the time it's administered, because you might only get seconds to minutes of recovery with that drug, especially in the world of synthetic opioids out there.
Yeah. It's so important, and every moment matters. I know I've talked to some people who have been, pardon me, on the wrong side of that overdose, and they were so thankful for how quickly folks got there, because they were going to have some anoxic brain damage, in terms of the fact that blood wasn't going to their brain. Every moment matters. And to that end, there was a study that came out about, I want to say maybe like 2 months ago now, maybe 6 weeks, that really caught my eye. This is from the CDC, looking at teens in particular, because one of the issues right now is that the demographic, which has shown the greatest increase in overdoses of late, has been those, I believe it was 13 to 17 specifically, the adolescents, because of this fentanyl contamination in all sorts of other drugs. It's something that I say a lot, is that this is a really bad time to be using street drugs, just straight. And we'll talk more about that in a minute. But the study in particular was showing that 60% of teens overdose in their own home. And another 20% after that, if they are going to overdose in one of their friends' houses. And that led me to feel like, and make the assertion, and I'd love to get your feedback on this, that if you are the parent of a teenager, you should have naloxone in your medicine cabinet, if not for your own child, then for someone who might be over at your house. Do you feel like that's too strong of a statement, or would you agree?
I think we're going to get there as society, Aaron. I really do. And I can't tell you any medical society that I'm familiar with that is promoting it at that level. But clearly yesterday, the FDA's decision was to really get this ubiquitously out into society. And I could see tremendous benefit if opioids are in the house, if teenagers are in the house. Why shouldn't naloxone be, right? And you're right. Right now, we have to understand that in society, opioid-related overdoses are the number one cause of death in adults under age 45. And so why wouldn't we make the solution as big as the problem?
Right. Or just basically, we all have fire extinguishers. We all have, there's so many common sense measures that we take. There's even an abundance of schools right now that have naloxone, as they should. Colleges having it on floors with resident assistants and such. But when the data says kids are overdosing in homes, I think we just got to be mindful of that. We got to be mindful of that.
And a study in a pediatrician journal just came out last month showing that the number one cause of death in kids under age 5, the number one cause, I should say, of drug overdose deaths was opioids in kids under 5. And, that speaks volumes that they're crawling around. They're finding these drugs in our medicine cabinets or reaching into our pockets. We need to be prepared. This is one way to do it.
Yeah. Well, so in terms of being prepared and looking to the future, what you do a great job in the book of outlining the different phases of the opioid epidemic, in terms of how really in the very early going, there was this overprescribing wave, followed by this wave of more of heroin overdoses as folks were potentially cut off or going to the street. Now we've seen this massive spike in fentanyl and synthetic overdoses. And now in the past, I'd say like 3 months, there's been a major alarm sounded on xylazine, which is an animal tranquilizer that's causing, I believe it's necrotic flesh and wounds that don't heal, things like that. And I'm just wondering from your perspective, where does this go? Are we going to keep seeing new adulterant? It feels like people, particularly on the street, are just upping the ante, right? In terms of, well, let's add in xylazine to give it longer legs, make the high last longer. Let's put fentanyl in with the heroin because it's cheaper to produce and packs more of a punch. Where do you see this trajectory going, or even how do you think we should be affecting it?
I think one of the biggest misunderstandings out there in the general public is the thought that, the people running the cartels are nothing more than uneducated third parties who grew up in impoverished neighborhoods and just traffic drugs. This is a multi-billion-dollar industry. And there was a study done just a couple of years ago by the DEA that showed that 42% of all synthetic opioids that were confiscated, all fentanyl pills that were confiscated, were enough in one pill to kill a human being. The first thing that comes to our mind is, why would anyone have half their product knock off people that are using it? And the reality is that there's algorithms behind this. The more that you make someone addicted for that other 42%, the more they disseminate it, the more they are hooked lifelong on this drug and require higher and higher doses as they build up tolerance. The benefits to them outweigh the risks of the casualties. And so that is so key for people to understand. This is not the day and age, I hate to say it, that I grew up in. When I was younger, kids experimented, and sometimes parents laughed it off and slapped our hands and said, "Don't use cannabis, Johnny," or "Don't smoke cigarettes, your breath will smell bad." This stuff is lacing everything out there. And I had a good colleague who lost their son to this very situation. They thought they were using cannabis and it was laced with something else. One pill can kill. And so I would tell all of our listeners, please, please talk to your kids about drug experimentation in this day and age. The monitoring the future studies that, it's almost ubiquitous by the time kids are getting into high school to have used one or more drugs along the road. And we can't afford to do that anymore. It's got to end. And part of that, Aaron, I will say, is this American mentality to use a pill to solve life problems. We know there's many roads to addiction. And, to summarize probably the top three, the one that we cause in the medical industry, which is putting someone on opioids inappropriately, and they use them thinking that doctor's got the algorithm down to make sure that these are being used safely, but the doses go up, the person becomes more and more dependent, and then over time becomes addicted. That's one route. There's people who use it for mental health issues, right? They're compensating for some reason in life that these drugs have a sedating, a calming presence over, and they become very dependent on using those drugs just to alleviate the mental health pain with life's problems. And then we've got the third party, which is the one we're seeing in kids. Let's have fun. Let's go to a party, right? Let's enjoy life. And as they use it a bit more and more, they find their body physiologically dependent on it. They need more. And then all of this leads to the same cycle. Every one of these paths needs to be evaluated. And if you're stuck in one of them, if you're stuck in any of them, your provider can help. Have that open conversation because we've got tools.
Yeah. Well, and the fact, I wholeheartedly agree with you about the fact that there's multiple pathways that lead to an overdose or an opioid overdose. I view it in some ways as a really awful pipeline where it's possible for sure that someone, and I'm actually working with people literally right now who had an overdose because their cocaine was laced with something, or they were taking another drug and it ended up being laced with fentanyl. And, they're very fortunate to be alive, and this is a big motivator for them. But a lot of times, particularly when we're talking about that more progressive use, whether or not you're talking about a young person developing, getting high for fun or for coping as part of their identity, or someone who gets prescribed a substance and develops a chemical dependency, is that it's a progression, and we can view an overdose or a fatal overdose as the end of a long chain of events, sometimes that goes for years, honestly, where if only we could have intervened earlier, this would not have had to end up that way. And from your perspective, where do you see those intervention points in terms of, we've talked a lot today about the prescribing side, but if you had to look at the other two, for example, for folks who are struggling with mental health concerns and who see opioids or substances as a way to cope with that, or the young people who want to gain acceptance in a peer group or not be ejected from a peer group that maybe they've been in but has started to shift towards drug use, what do we do? How do we get in there before things get really bad?
Aaron, I think of the two examples you just used, you've used the concept of the relationships as really being one of the primary, opportunities to intervene. For those individuals struggling with mental health issues, oftentimes those stem out of poor relationships. And so speaking with counselors, going to your provider and saying, I'm struggling with problem A with my spouse, or, I have a loved one that's disassociated with me, and I feel that these drugs I've been taking help alleviate that. Is this the right road to go? Starting with those open conversations is going to be key to getting someone to the help they need, not necessarily just coping with the symptoms of what's deeper. Same thing goes with teenagers that need to be in a peer group, that need to be accepted, that need to experience the high. Kids don't really develop their whole frontal lobe, that executive decision-making center, until they're in their mid-20s. And that's the go, no-go switch for the human being, especially as we become adults, to say, this is nuts. This isn't going to help me in the long run. This is a bad decision. And if they can't make that switch on and off early in life, then the parents play a critical role in talking kids through to help them make that decision. And I would say, as a parent, my goodness, set the ground rules in your house. That's oftentimes what we're seeing in America is this decline in parenting, right? Be more of a friend to your child than you are an executive decision maker on what can and can't occur under your roof. And kids are likely to experiment. We know that. So start off with those honest conversations and then set ground rules. Here's what our expectations are for you. Here's your reward, by the way, for doing things well, for not going out and partying and drinking on weekends. Here's your reward for staying in line and keeping your grades up. Here are the consequences if we find drugs in your underwear drawer. Here are the consequences if we hear that you're continuing the relationships with this group of very unsavvy people that we know are going to be a negative influencer. And don't be afraid to escalate. If and when things are getting worse, pediatricians are key, and they get a lot of training on this topic. They can connect you with resources to take the next steps if things have devolved.
Yeah. Well, that's the impact of parents on that process. I'm also thinking about the first topic, or one of our first topics today, about your care team and talking to them about it. That's why this is so essential. I know that actually very recently in the last few months, the director of NIDA, Dr. Nora Volkov, she advanced an idea of a term. I'm not sure if it's going to get legs for a couple of reasons, but of pre-addiction, of this idea that there's an unhealthy use trend that it's worth giving a name to, so that we could potentially get more federal funding to treat, what we in the field oftentimes call prevention. But it's harder to get funding to prevent something that isn't here than to get funding to treat something that that we can say is here right now, because it is a process, and it's one of those things where I'm sure you've had the same thing happen many times in your professional life, where you meet someone, you meet a parent or you meet a loved one who was just so shocked to find someone having had an overdose, or like, I knew that they were doing one thing, but I had no idea it had gotten this far, or people being just absolutely blindsided by what happened. And I feel like that all flows from that lack of knowledge, that lack of communication, of people feeling like they have to keep it hidden. And if we can all just talk about it with our loved ones, with our care teams, not feel like it's a shameful secret that we've got to keep inside, that would open the door to so much improvement.
Erin, you're so right. The American Society of Addiction Medicine talks about addiction as being a disorder that manifests in biological, psychological, social, and spiritual type of manifestations. And that's because addiction impacts all domains. When all those domains are impacted, people feel so ashamed. I have people that can hardly talk about the story of addiction, even to the point when they're recovered, because they look back and feel that it's such a moral failing on their part. And the reality is, the more we understand addiction, the more we understand that this is a wiring problem, Erin. This is a problem, an expected problem, that opioids will have on the brain over time. And one of the top things I tell my patients is, opioids don't care why they've entered your body. They're going to have their impact independent of why they're there, which means if I take an opioid today and I take this long enough, I'm going to start experiencing those side effects and those rewiring properties. Whether or not I've ever endorsed they can do that to me. Patients need to understand this is a drug problem, right? Not a person problem in most situations. And once those drugs start having their effect, the brain chemistry changes, the wiring changes, our ability to problem solve changes. And that's why we need third parties to help us through it. So that fear, that intimidation, and that societal stigma, it's going to go away, Erin. I believe that the more we talk about this as a biologically derived process that's managed in all these other arenas through comprehensive training of all of our medical professions, and then comprehensive treatment programs for those experiencing the problem.
Yeah, well, extremely well said. I think that is the perfect way to stick the landing on our conversation today. So, Dr. Holly Geyer, thank you so much for coming on the show. And listeners, please pick up her book, Ending the Crisis. It is truly a treasure trove of information. I think you used the word, Holly, being a compendium of information. I was astounded. I was like reading my brain in some ways, not to be self-promotional, but I'm like, oh my gosh, he's talking about this and about that. And there's all this detail in this area and that area. It was amazing to see it all in one place. So truly, congratulations on the book. It's a fantastic resource.
Oh, Erin, privileged to be here today, and a very special thank you to you and your industry. And I mean that as much as we see as physicians trying to really micromanage all of the problems that we've caused within this arena, the role of integrating what you guys do day in and day out, that psychosocial aspect is absolutely critical to ensuring that we're offering comprehensive treatment and recovery options to our patients. So you guys are a true blessing to partner with, and it's an honor to be with you, one of the leaders in the field and the industry today.
Well, thanks, Holly. And thanks as always, listeners, for tuning in, and we'll catch you again next week.